Hello, this is Roxana Mehran from New York City, Mount Sinai Hospital. It is really my distinct honor and pleasure to be with you on this Cardiovascular Innovations Digital 2020. I want to thank the course organizers for arranging this digital format and especially incorporating a talk on updates in PCI pharmacology. It's important for you to note my disclosures specifically to the Twilight study that I was the global PI of, with grants from AstraZeneca and sponsorship from the Icahn School of Medicine at Mount Sinai. I wanted to talk to you about two topics, the latest in post-PCI pharmacology. The two hot topics are genotype-guided antiplatelet therapy and P2Y12 monotherapy. The first is on genotype-guided antiplatelet therapy, and the Taylor PCI was the largest trial that was conducted most recently and presented at the American College of Cardiology as a very important study to evaluate the impact of guiding our antiplatelet therapy choice based on CYP2C319 loss of function status, and whether or not if these patients who had this loss of function and were treated with ticagrelor instead of clopidogrel, there would be an improvement in their outcomes versus prescribing a normal clopidogrel in those patients. So over 5,000 patients were randomized to the conventional versus the genotyping, prospective genotyping arm. The conventional arm received the clopidogrel, and they still had an important genotyping at 12 months. The prospective genotyping arm received their genotyping if there was a CYP2C319 loss of function allele present, that those patients were given ticagrelor 90 milligrams as opposed to those who then received clopidogrel. The primary outcome was a pretty large endpoint, and they followed these patients for cardiovascular death, MI, stroke, and stent thrombosis. And as you can see right here, they didn't meet the statistical significance of superiority for the genotype-guided therapy. But actually, if you really look, there was an improvement in the outcomes. If they had larger numbers of patients, they probably would have shown a difference. But the truth is that the early benefit was seen very, very early on, even in the first 180 days, an important benefit. Bleeding rates were very similar between two strategies, so it really is an interesting concept, and a longer-term follow-up is something that might be interesting in this patient population. What about P2Y12 inhibitor monotherapy? This is a new paradigm. We always continue aspirin and drop the P2Y12 inhibitor, and you wonder why, because there are many issues with aspirin, such as aspirin resistance, bleeding risk, the important gastrotoxicity that we see with increased gastric bleeding. Aspirin also might abolish or decrease the proposed antithrombotic effects of P2Y12 blockers in vivo. This was examined by Paul Armstrong on a very good study with prasugrel, where there is this very interesting mediation of amplification of antiplatelet effect of inhibitory prostaglandins such as PGI2, which you see with aspirin. And in the presence of a strong P2Y12 inhibitor, you wonder, what is the aspirin doing? What additional inhibition of platelet aggregation is it providing? It might be nil. So we designed the Twilight trial. This was a trial that incorporated patients with high bleeding and ischemic risk. The physician was sending the patients home on aspirin and ticagrelor, but it wasn't just that. You needed at least one clinical or an angiographic criteria that would put you into a complex category. 9,006 patients were enrolled for an open period of 3 months with aspirin and ticagrelor open label. At the end of 3 months, all those patients were evaluated in person. There was a pill count to evaluate their adherence to the ticagrelor and aspirin, and evaluation of their outcomes. If there was no ischemic or bleeding event, they were randomized to aspirin plus ticagrelor or ticagrelor plus a matching placebo and followed for the next 12 months. And then beyond that, once the study period was over, there was an open observation period for standard of care. What was observed, as we had hypothesized, a superiority hypothesis for intention to treat in reducing bleeding 2, 3, BARC 2, 3, and 5 bleeding, which was significant of 44% reduction with numbers needed to treat of about 33 patients to reduce bleeding in these patients with absolutely no ischemic harm, with the P non-inferiority meeting the non-inferiority margin and showing a no harm whatsoever, very similar key secondary endpoint of death, MI, and stroke in these patients. So right then and there, we showed that, in fact, aspirin was adding very little benefit. The only thing it was doing is increasing bleeding. And then we said, well, what about focus on complex PCI, the kinds of patients in whom we're really worried about dropping aspirin because these are complex lesions like bifurcations, long stents, left main disease. We had about 2,300 patients in that, and this data was presented last ACC. And in that patient population, there was no question that complex PCI patients did have, and they were all in red, did have a much higher rates of bleeding, and aspirin plus ticagrelor had the highest rate of bleeding in those patients with complex PCI, and it was significantly reduced. The bleeding was significantly reduced in those complex patients. And in terms of reducing or a differential in the ischemic complications, you can see that there was absolutely no issue. The P interaction is negative, but the complex lesion patients who had complex lesions actually did have a little bit less death, MI, and stroke, but P interaction is negative, so we can't say that there was an important interaction. So that, in fact, the complex patients did perfectly fine on the ischemic outcome without aspirin. What about the diabetic patient population? A large group of patients who really do have a requirement for perhaps better coverage with more potent agents. In the completely randomized patients, we had 2,600 diabetic patients, 37%. And we had follow-up in 99% of these patients with really, really good adherence to both ticagrelor and the study drug. What we showed in the intention to treat analysis that in diabetic patients, BARC2/3 bleeding with ticagrelor monotherapy was significantly reduced. You see a 35% reduction, and in fact, we are seeing a lower event rate in placebo arm in ticagrelor monotherapy, even though it's not much different, 4.6 versus 5.9, certainly no sign of harm. So very important, two complex lesions, diabetic patients, and we showed very similar effects with acute coronary syndrome patients in Twilight. What about the most recent study, the TICO randomized study in ACS patients at the time of PCI, 3 months of DAP versus 12 months of DAP with ticagrelor monotherapy after 3 months. Here, the net adverse clinical outcomes, which included bleeding and ischemic complications, was in favor of a ticagrelor monotherapy after 3 months of DAP. This was mostly driven by reducing bleeding complications with no difference in their ischemic endpoints. So the take-home message of the best top-line results for PCI pharmacotherapy is that a genotype guided therapy was not superior at reducing adverse events, cardiovascular events, compared to standard therapy. So unfortunately, we can't incorporate that, and maybe in some certain cases you might want to do that. And that a P2Y12 monotherapy with a short course of DAPT, especially when you have ticagrelor on board, reduces the risk of bleeding without compromising ischemic protection in different subsets, including those high-risk subsets of complex lesions, ACS patients, as well as diabetic patients who have undergone PCI. Thank you so much for your attention, and it's wonderful to be with all of you, even though it's virtual. I can't wait to see you all in person.